We need to have lunch with JC. I just want to show you my cool guy. Come on, JC. Focus.
I don't know.
Good morning, remote attendees. Doing a sound check. Brian Alston, can you hear me? Excellent, thank you. The meeting will be starting in a few minutes.
Okay, good morning, and welcome to the Cook County Health Board meeting of Friday, May 29th at 9 a.m. I am Raul Garza, and I have the honor of serving as chair of the board. And so at this moment, I'd formally call the meeting in order and ask the secretary to call the roll of the attendance, please.
Director Bott is absent. Director Harrington is absent. Director Kim? Director Kim, did you? Thank you. Vice Chair Lowry?
Present.
Director Masuda Barnett? Director Ryder? Director Robinson?
Present.
Director Sorrell? Is absent. Director Staines? Here. And Chair Garza?
Present.
You have a quorum.
Thank you, Madam Secretary. The next regular meeting of the Cook County Health Board will take place on Friday, June 26th at 9 a.m. Do we have any directors that are participating remotely for this meeting?
Not at this time.
Okay. So we will move on to item 2, and we're honored to have our Chief Strategy Officer, Andrea Gibson, stepping in to take item 2, employee recognition.
Great, thank you. This is Andrea Gibson, Chief Strategy Officer. We're going to start with new hires and promotions. So join me in welcoming some new leadership hires. Cherie Boyd, Chief Operating Officer, Ambulatory Services. Do you want to stand so everyone can see who you are? Okay, great. Sincerelyn Lewis, Nursing Manager, Stroger Hospital, and Shannon Wofford, Nursing Manager, Stroger Hospital. And also congratulations on several promotions. Dr. Shweta Gupta, the Chair of the Division of Hematology and Oncology, Daniel Kakrowski at CERMAC Medical Surgical Clinical Director, Ariana Relaford, Senior Manager of Delegation and Vendor Oversight for Health Plan Services. So welcome and congratulations.
Yeah.
Now we'll go to recognitions and announcements. And if you are present and you hear your name, please stand and we'll give you a round of applause. The Good Catch Award winner, Chirag Patel, PharmD. All right, we've got quite a few Institutional Research Day winners, including Samuel Stark, Amari Faison, Joshua Ibarra, Jay Singh, Romano, Subhashish Saha, okay, everyone's standing up, good. Alishwara Anwari, and apologies if I'm mispronouncing, Julia Sidor, Daniel Hinman, Samuel Odall, Grace Yoon, and Chiranisha Jackson. So join me in congratulating the team on their achievement. Thank you. Next up is the Nurse Clinical Excellence Award winner. So again, please stand if you hear your name. And the Nurse of the Year, Anisha Powell Humphrey. I don't know if she is with us today. But also some of the other awards, the Rising Star Award for Charlotte Langell, Clinical Nursing, Indu Abraham, Advanced Practice Nursing Educator, Kathy Roberts, Advanced Practice Nursing Leader, Karen Warden Thomas, Correctional Health, Kim Villa Rael, Advanced Practice Nursing Preceptor, Manju Thomas, APRN of the Year, Meredith Berlin, Volunteerism, Simi Joseph, I know she was here, Patient Care Support, YEP, Preceptorship, Patricia Taylor, then Public Health Care, Michelle Spikes Kane, Education Mentorship, Priya Purasar, Community Care, Roylandu Watchun, Partners in Nursing, Tara Dunisgudi, Leadership, Binsi Puthuri. So thank you very much and congratulations. All right, we want to also extend congratulations to clinical nurse leader LaTanya Smith for winning the People's Choice Award for her poster presentation. Next up is a congratulations to Shalise A. Roberts, public health nurse, who is recognized as a National Black Nurses Award recipient at the 38th Annual National Black Nurses Day program, as well as Michelle Spike Payne, I don't know if she's here, Associate Director of Nursing, also served as keynote speaker. So congratulations. The Chicago Defender recognized several CCH leaders for being named as Chicago Defender Vital Signs honorees, including Donica Austin Cathy, please stand. Denise Gilbert, is Denise here? I think Denise is here. Denise Gilbert and Dr. Durrell Alexander, and I don't think Dr. Alexander is here, but congratulations. We're also pleased to share that the Navy Medicine renewed the commitment to excellence in trauma care. Cook County Health and the United States Navy officially reaffirmed the partnership on April 28th with a new memorandum of understanding, expanding training opportunities and deepening a collaboration that strengthens clinical excellence, readiness, and community impact. The next recognition, Cook County Health joined Vitalant, our partner blood center, for a press conference at the beginning of May to raise awareness about the need for blood products during labor and delivery. The event supported Donate for Mothers, Vitalant's initiative to inspire people to donate blood in honor of the moms who inspire us. We held a second Donate for Mothers blood drive on May 20th. So next, is the Maternal Health Care Roundtable. We had leaders from Cook County Health, Cook County Department of Public Health, and County Care, who were joined by Senator Dick Durbin and Board Chair Raul Garza on May 8th to discuss the health systems initiatives that support maternal health, as well as opportunities to further reduce disparities in care and improve outcomes for the residents of Cook County.
Okay, I think that concludes our recognition, but it also illustrates all the great things happening around the county by great people that are committed to their work. So thank you, and one more round of applause to all those recipients for coming in. We'll now move to item 3, public testimony. And Madam Secretary, are there any speakers registered to provide virtual or in-person testimony, or have they sent in written testimony to be included into the record?
We did not receive written testimony, but we do have one registration from Juan Calderon.
Okay, I would invite Mr. Calderon to please come to the podium to offer that testimony.
Good morning. Good morning to the assembled members of the Cook County Board of Health. My name is Juan Manuel Calderon, born and raised in Chicago's Humboldt Park community. I serve as the Deputy Executive Director of the Puerto Rican Cultural Center. I am here to advocate on behalf of communities under federal attack. I stand here to advocate for the trans community. I stand here to advocate for the Puerto Rican community. I stand here and advocate for the Mexican population, for Black civilians, and for our HIV-positive community. According to the Chicago Department of Public Health, Healthy Chicago 2025 Strategic Plan and its 2024 HIV/AIDS data brief, an alarming racial disparity continues to torment our communities. Latinos and Black individuals account for nearly 50% and 38% of new cases, respectively. Citywide, Latinos are Only about 30% of the population and Black individuals has 27%. That is nearly double the proportion of cases relatively to the Chicago demographics. The Humboldt Park neighborhood, the PRCC's home and neighborhood of focus, maintains one of the highest per capita diagnosis rates citywide, exceeding 50 cases per 100,000 residents. There are other neighborhoods like Inglewood, Douglas, Uptown, Garfield, to name a few, who have seen alarming increase of HIV and AIDS diagnosis. This is set to only worsen. Illinois, Cook County, and Chicago have not earmarked any new money for testing, education, and care, despite long evidence, scientific evidence of its effectiveness, and furthermore, seeing it on the news, respectively, in these past few months. Furthermore, according to the Chicago Sun-Times, $29 million in federal HIV prevention grants for Illinois are set to sunset by the Trump administration. The Puerto Rican Cultural Center has personally seen millions of dollars lost in cuts from the city of Chicago and the federal government. Services for gender-affirming care, restorative justice, initiatives from the Department of Justice, mental health, housing opportunities for people living with HIV/AIDS, and linkage to care, not only for the LGBTQ community, have been cut by the Chicago Department of Public Health through federal pass-throughs by the federal government. Our communities already face economic barriers, and we're talking about servicing the poor.
30 seconds remaining.
And social equities that weaken their access to HIV prevention and undermine the rights to a dignified life. We are calling on you to provide life-saving and affirming support to nonprofit grassroots organizations like the Puerto Rican Cultural Center that have experienced large funding cuts and has a 10-year history of success. We ask the Cook County Health to partner and ensure that public health jobs and services are in our communities that are impacted by this epidemic. Our community request is to invest in Illinois cultural designated districts. Recently, a law appropriated by Governor Pritzker that will serve 7 districts in Cook County that will invest in public health, that will invest in the public health and wellness pillar of Illinois cultural designated districts by the Department of Commerce and Economic Opportunity. These are communities that are experiencing gentrification, displacement. These are where we have data, and it's written in law, it's a state law, that these communities are experiencing large numbers of health disparities and access to food security and access to not having access to many other things. And now we are impacted by the cut of the SNAP program for our constituents. So I strongly urge the board to look at the grassroots community-based organizations and begin to invest in them in current line items that don't have Cook County investment, only federal ARPA dollars that are set to sunset. Thank you very much for your time.
Thank you, Mr. Calderon. I'll now move to item 4, board and committee reports. Item A, minutes of the April 24th board meeting, and I will present those and ask if there are any corrections that are needed. Okay, I'm asking for a motion to approve item 4A, the board meeting minutes of April 24th, 2026. Do I have a motion, please?
So moved.
Thank you.
Second.
Thank you, gentlemen. Is there any discussion or questions, please? Hearing none, all those in favor say aye.
Aye.
Aye. All those opposed? Okay, that motion carries. Thank you. And I would like to welcome and recognize both Directors Bott and Harrington as being present in person. Welcome, gentlemen. Item 4B, minutes of the April 15, 2026 Quality and Patient Safety Committee meeting, which, okay, so now that we have Director Bott, good timing, Director Bott, we'll hand that over to you.
Thank you, Mr. Chair. Quality and Patient Safety Committee met on Friday, May 15th at 9 a.m. Next meeting of the committee will be held on Friday, June 12th at 9 a.m. The committee approved the following action items, which are included in the minutes. Approved 1 Stroger Hospital Department Chair reappointment, 2 Division Chair reappointments. Approved Stroger and Providence Hospital Medical Staff appointments, reappointments, changes. Approved the County Care Cultural Humility and Cultural Linguistic Appropriate Services Program. Committee received the following reports, which are included in the minutes: grievance and patient experience report, patient community member experience data and updates for Stroger Hospital, Providence Hospital, ACH, and Cermak County Care, and performance improvement update. If there are no other questions on the minutes, they're being presented for the board's consideration at this time.
Thank you, Director Bott. So I will ask for a motion to approve item 4B, the minutes of the meeting of the Quality and Patient Safety Committee of May 15, 2026, which included approval of the following items: 1 Stroger Hospital Department Chair reappointment and 2 Division Chair reappointments. I've got a few more things, Director Harrington. I'm anxious as you are.
Director Harrington.
Got to complete the agenda. The Stroger Hospital and Providence Hospital medical staff appointments, reappointments, and changes. And then finally, the County Care Cultural Humility and Culturally and Linguistically Appropriate Services Program. Mouthful. Now I'll ask for the motion.
So moved.
All right.
Seconded.
Thank you, Vice Chair. Are there any corrections or discussion? Okay, hearing none. All those in favor, say aye.
Aye.
Aye. All those opposed? Okay, that motion carries. At this point, we'll move to item 4C, minutes of the May 7th, 2026 Finance Committee meeting. And our colleague, Director Ryder, will take us through that review.
Thank you, Mr. Chairman.
Sure.
The committee considered the Finance Committee met on May 7th at 9 a.m. Committee considered the following action items, which are included in the minutes. We conditionally approved 21 contracts, procurement items. There are no contracts that are pending review by contract compliance. On the screen, you'll see the contractual requests from the Finance Committee meeting, whose fiscal impacts are greater than $1 million, which are highlighted for your information. The committee held a lengthy discussion of requests related to Guidehouse Managed Services, LLC, for revenue cycle services. During public testimony, information was provided by the public speakers regarding progress made in filling positions pursuant to the arbitrator's order in the Guidehouse grievance, included in the minutes as attachment number 1. Although the committee has moved to an every other month reporting cycle for the agency reduction report, the committee requested to have monthly reporting on progress in filling the positions in the revenue department relating to the Guidehouse contract. We received and filed grant award related items. The committee received the following reports, which are also included in the minutes: the MBE WB report, report of March financials, the agency reduction report. During review of the financials, the committee held a discussion on topics including dish payments and operating trends. It was requested that the committee have a further discussion at the next meeting, so there is a level setting and everyone has a full understanding of what is backing up the data. Mr. Chairman, the next regular meeting of the Finance Committee is scheduled to be held on Thursday, June 4th at 10 a.m. I'm excited to see everyone there. If there are no other questions, the minutes are being presented for the board's approval at this time.
Thank you, Director Ryder. I'll ask for a motion to approve item 4C, the May 7th, 2026 Finance Committee meeting minutes, which contain the following action items: conditional approval of the contracts and procurement items pending review by contract compliance, and receiving and filing of the grant awarded related items. Can I have a motion, please?
So moved.
Thank you, Vice Chair. Second.
Second.
Thank you, Director Harrington. Is there any discussion or a question or comments? Okay, hearing none. All those in favor say aye.
Aye.
All those opposed? The motion carries. Thank you. Item 5, action items, let's see, contracts and procurement items, none are being presented. So we will move to item 4B. And I think we're making good pace, but I just want to remind the board that we are going into a closed session, so I'd like to keep us moving at a good pace as we get into the final presentation. So with that, we'll move to 5B, approval of the Cook County Department of Public Health Building Healthy Communities 2030 Plan, presented by Dr. Kiran Joshi, who serves as the Cook County Department of Public Health Chief Operating Officer. Go ahead, Dr. Joshi.
Kiran Joshi, Chief Operating Officer, Cook County Department of Public Health. I am here with two colleagues, Frankie Shipman-Amuo, Senior Director for Community Health at CCDPH, and Dolores Walker, Regional Health Officer at CCDPH. I really want to take a moment to acknowledge that this is my third round of community health improvement planning with CCDPH, and I think largely because of the leadership of these two consummate public health professionals, as well as three folks who are listening in virtually, and they are Hannah Kite, who's our Director of Community Behavioral Health, Amy O'Rourke, Director of Chronic Disease Prevention, as well as Michelle Spikes-Kane, Associate Director of Public Health Nursing. It's because of their efforts that this planning process has been successful, and I'm confident that the implementation will be equally successful. You're going to be hearing this morning about a vital part of our work that is really intended to drive public health action across suburban Cook County for the next 5 years. So this is really important work. It's formative work. And I'm going to turn it over to folks that are much better positioned than I am to speak to the details. Dolores, take it away.
Thank you so much, Karen. Like Karen said, my name is Dolores Walker. I'm a Regional Health Officer with CCDPH, and I just want to thank everyone. It's an honor to be here to present this labor of love that we have worked on over the past couple of years, our Community Health Improvement Plan, which we market as Building Healthier Communities 2030. Next slide, please. Before we get into our current cycle of our plan, we wanted to start off by really highlighting some of the successes of our previous plan. One of the things that we really want to call to your attention is that this is a community effort, and it's truly a community health improvement plan. So the successes that you see are not the successes only of CCDPH. These are the successes also of the community. So together with the community, over the last plan, these are just a few snippets. And it's hard for me to see that far, even with glasses. So, so bear with me. Thank you so much. I think I need a new prescription.
I'm benefiting from this as well.
Thank you. So we had almost 600 community health worker resources distributed in 2024. Almost 8,000 naloxone kits distributed between 2023 and 2024. 87 of those doses we know were used in specific overdose events, preventing overdose deaths. One of our treasured partners, Sisters Working It Out, SWIO, provided over 2,000 food provisions or food boxes for families in need in 2023 and coordinated 334 free Uber rides for cancer patients to receive treatment. We also looking kind of more long-term and systems level, we're able to shift $15 million+ towards healthier local food sustainability through our good food purchasing program. If you can scroll, there you go. Thank you. And then finally, we had two things, supported the passage and implementation of flavored tobacco restrictions, and also had 14 students who received community health worker certifications through our high school pipeline program. So those are just a few key highlights that we wanted to share with you from our community health improvement plan that is sunsetting as we begin to move into our current one. Next slide, please.
When you say sunsetting, these were federally supported most part?
This is a state, required plan, and when I say sunsetting, this plan is sunsetting because it's in a 5-year cycle. So each plan is 5 years. So our current plan now will start this year and run through 2030.
So there's no funding related to these that's required?
The efforts that you heard Dolores describe in terms of previous successes would have been funded by a mix of funding ranging from corporate to grants to COVID grants to ARPA.
Thank you. So as we move into the presentation for today, we wanted to just provide you with a brief overview of BHC 2030, the process behind this, some of the plan highlights from this current cycle, the implementation strategy, and a few next steps. Next slide, please. So BHC 2030, many of you have heard of it before, have been on some of the briefing calls, but so I won't belabor the issue, but it is our community health assessment and improvement plan. And like I said, it is a 5-year cycle and it's required by IDPH. But what's more important than that is that it's an opportunity for us to build trust with the community. It's an opportunity for us to partner with the community. And it's also an opportunity for us to create synergy throughout suburban Cook County around health, improving health outcomes and driving health equity. So also, I just wanted to highlight that the findings from the community health assessment directly inform the health improvement plan. And that establishes our shared priorities, measurable goals, and coordinated strategies across sectors. And so we will talk a little bit about that a little later when I hand it over to Frankie. I'm going to stop there and go to the next slide, please. Before I go to the next slide, so sorry about that. The last bullet point I do want to highlight that this plan was not created in a bubble. We definitely were intentional about aligning our efforts, our plans, our strategies with that of the Cook County Policy Roadmap and also Cook County Health Strategic Plan. We also looked at other plans, including the Illinois State Health Improvement Plan as well. Next slide, please. This is our timeline. Like I said, it has been a labor of love, and several partners have worked on this with us. We've been working on this plan for about 2 years, leveraging partnerships with Illinois Public Health Institute, the Alliance for Health Equity, to work with them on some of the assessments and surveys and focus groups around this, around getting information to feed this plan. Next slide, please. And again, just want to really call out that this plan is not just the plan of CCDPH. We had several external partners that worked with us on this plan, and we wanted to highlight them and just show them some appreciation. We also, as Karen said, we had several internal partners at CCDPH as well as CCH that have worked on this plan with us. So just want to publicly thank them for that. Next slide, please. More acknowledgement. And then the components of Building Healthier Communities 2030. Thank you so much. The community health assessment is one side, and then the community health improvement plan is the other side. So but they are all tied, they're both tied together. So the community health assessment feeds into the health improvement plan. And under the overarching community health assessment, there are 3 assessments that we do. So it's the community partner assessment, the community status assessment, and the community context assessment. And with these assessments, it's a mixture of qualitative and quantitative data that we're collecting. So we're doing surveys throughout Cook County. We're doing focus groups throughout Cook County. We're also assessing partners to understand the alignment, the resources that partners bring to the table as well. Next slide, please. Talked about that a little bit, so I won't go into it just to save time. I know you all have a closed session. Next slide, please. Next slide, please. So our prioritization process, in July, we convened over 50 partners, many of which came from Cook County Health, as well as some of our offices of the commissioners had representation as well. We had other sectors that were that participated from July through September, regularly meeting to create these goals, these strategies, and these objectives collectively. And once we did that, we used the framework, which is MAP 2.0, a framework by NACCHO that really focuses on achieving health equity. And we developed 3 priorities: mental health and substance use, chronic disease, and maternal and child health. Next slide, please. And I'm going to turn it over to Frankie to talk about our strategy.
Thank you, Dolores. That's perfect. Thank you so much. Good morning, everyone. I'm going to talk about the 3 priorities. The order that they're in is alphabetical, so one is not more dire than the other. We're first going to start with chronic disease. Before I do, you have our executive summary in front of you. If you want more information on our justification for why this priority was chosen, the statistics, the contributing factors, you can go on page 8, 9, and 10, and they will tell you some statistics and contributing factors for each of these when it comes to suburban Cook County. So the first priority in chronic disease, this was a collaboration in establishing this priority, the goals and the strategies, a collaboration between Cook County Department of Public Health and our partners. Within these 3 goals and 16 strategies, Cook County Department of Public Health leads some, and in others, our partners lead and we support. I'm going to give an overview of the goals, and then I want to highlight some of the key strategies that we're currently working on with our partners, either in support or leading. So the first one is focused on access to healthcare and preventative care. And the second one is looking at that infrastructure of the home, along with physical activity and then climate resilience. And then the third goal is focused all about nutrition. So I want to highlight some key strategies that we've been working on in partnership. The first is launching our anti-vaping campaign. This is set to launch in the summer, and this is building on the success of our previous campaign on Friend Tobacco. The focus on anti-vaping is also focused on youth and young adults, and our plan is for distribution and dissemination for schools, also behavioral health treatment centers. The second goal that I want to focus on is a benefit hub, and this is led by our partners. We have the Chicago Food Depository, and this is all focused on that first goal in improving access to healthcare. This is for Cook County residents to get better access to public services such as SNAP and Medicaid. This is building more awareness on what the changes are, what their rights are, and this is something in which the Cook County Department of Public Health is an anchor partner supporting Chicago Food Depository in. And then I also wanted to talk about our technical assistance to 15 municipalities. This is a partnership we have with Active Transportation Alliance in order to provide technical assistance to municipalities for applying for state funding, state transportation funding, in the hopes that it will build a better program design, a better application for building safer walkways, bike, and walking paths in their communities. So I'm going to move to the next priority. Next slide. And that's maternal child health. So with maternal child health, we had 3 goals. Again, if you look on page 9, you'll see the rationale for why this is a priority, key findings, and also contributing factors. One of the other things I wanted to highlight is throughout this executive summary, this is just a snippet of some of the strategies that we're working on. But if you look in here, chronic disease on page 12, maternal child health on page 20, you'll see the extensive strategies that we and our partners developed for these different priorities. So these 3 goals and 15 strategies, I'm going to highlight a few of them. The first goal is elevating that maternal care and making sure that we are working on equitable access and quality of care. The second is all about building that awareness and education for the different maternal child health services and trainings. And then the third is all about culturally responsive care, particularly pediatric care, and when we're addressing those social determinants of health. So some strategies that we've been working on, the first I'm going to highlight is our work that we're doing when it comes to creating safe sleep partnerships. And that's a partnership that we have been working on with training for the ACHN staff. The second I want to talk about is Healthy Beginnings. And Healthy Beginnings is an initiative that we launched in January of 2026. This is focused on that community home-based care coordination model, and it's building that awareness, that referral to services, doing health screenings, and also social screenings for prenatal, postpartum, and extended infant care. And then the third, I want to highlight the partnership that we have with our colleagues at Cook County Health to offer a cadre of services and build awareness of the extensive services with OBGYN departments, with ACHN, so that clients understand the depth and the range of services we offer in maternal child health, so that they can decide on which service is right for them based on their needs. So I'm going to move on to priority 3, the next slide. And this is mental health and substance use. If you look on page 10, you'll see those key factors and drivers for why this was a priority. This has 3 goals and 14 strategies. And on page 26, you'll see the full list of all of the strategies that fall under these 3 goals. I'm going to highlight a few. If you look at the first goal, you'll see that this is all about building and strengthening our partnerships. So partnerships between government and coordination with community-based organizations and treatment providers. This is done in partnership so that we can address those systemic barriers. The second is all about increasing our coordinated crisis care systems. And I'm going to talk a little bit about that, but the whole goal is for those healthy connections, healthy environments. And then the final is addressing those structural, or what we're calling upstream drivers, that are perpetuating trauma and substance use in suburban Cook County. So to highlight a few key strategies, first I want to highlight an initiative that the Bureau of Economic Development is doing, and that is the Community Information Exchange, in which the Cook County Department of Public Health is a partner. This is trying to close that referral loop for clients to make the process more seamless and less burdensome for them. It's confidential data exchange, a partnership and governance between government and treatment providers and community-based organizations. It's in its pilot phase now. And I also want to highlight the crisis care report that we released. This was in November of 2025. The press conference was held in partnership with many partners and commissioners to talk about the barriers and also recommendations for coordinated crisis care, one of which is the promotion of 988. This was a national initiative that was launched in 2022, and it has a relationship to the decrease in youth suicides since 2022. In our promotion, we are working to make sure that this is culturally responsive with our partners, trying to elevate the difference between 988 and 911. And then finally, I want to talk about restorative justice. Our work with schools and the promotion of restorative justice is something that is coming to fruition very shortly. We will be releasing a report, and we also will be hosting a panel with school partners and other partners to talk about best practices in the hopes that our guidance can highlight those types of best practices that can be reviewed and applied in schools and for youth and young adults around restorative justice. If we can go to the next slide. So we've laid out the strategies, the goals that we and our partners have developed. This is the implementation. The best way that we can continue this partnership is through what we're calling a community partnership collaborative. And this is basically going to be a steering committee along with action teams that are going to focus on applying and achieving and implementing these strategies. Each action team is going to fall under one of the priorities. It's going to be co-led so that we have community ownership with this. It's going to be addressing, what are we working on when it comes to these different strategies? How can we better coordinate? identifying metrics and measuring. And we also have in that fourth bucket an area where we can have other action teams. If community is identifying other areas that they feel are a priority, then those would be action teams as well that we would work in partnership with those community organizations. And so this community partnership collaborative is going to be the key in how we are not only implementing these strategies, but also measuring and then reporting out on our progress. If we could go to the next slide. This is just a snippet of what Dolores had already shown when it comes to the road ahead. Right now, we are speaking with this board along with the Board of Commissioners in June for approval. Our intent after submission to the Illinois Department of Public Health is to kick off our BHC 2030 through a press event in early September, and very shortly thereafter launch our community partnership collaborative in September as well. The intent with these regular meetings and work on our strategies is to have our first report that is presented and disseminated in January of 2027. If we can go to the next slide. This is a summary of everything that we talked about, the importance that we held with our steering committee and our community partner engagement to develop those priorities, goals, and strategies, making sure that our strategies were measurable, and highlighting our implementation plan using our community partnership collaborative and our next steps to ensure that this is approved, submitted, and launched by early September. Then the next slide is, I believe, the end. Thank you very much for your time. I'm going to pass it over to Dr. Joshi so that we can take questions.
Any questions?
I have a question about previous successful, activities that you had, including CHWs and vaping and all of that. I want to know, it sounded like you ended this thing you have done previously, and then you have new plans, but I want to see how previous success and achievement actually feed into your current plans for the future.
Thank you, Director. I think based on the way we presented it, I could understand that that's how it came across, but it's really not discontinuous at all. Projects will continue for years because that's the time scale, those are the time scales that we work on. Some projects do end over time, but in the meantime, we've started new implementation. So for some of the work that you're seeing us reference, for example, the Healthy Beginnings home visiting program, that's a strategy in our plan, but we weren't waiting for plan finalization for that strategy to begin. We kicked that off months ago in January. Thanks.
Thank you. It was a great presentation. So first of all, thank you for that. Relative to the partners, which I saw listed in the context of the priorities, would you talk a little bit about who are the partners? How are we going about forging those relationships?
I can talk about the partners. So Dolores had mentioned how we were engaging with assessments, focus groups, et cetera. Then those partners were identified through our current relationships and also existing relationships that those partners had. We're not limiting it to those partnerships. So if you have partners that are interested in prioritizing chronic disease, maternal child health, or mental health and substance use, it's important to let us know. We also have feedback right here as well, but we do take the recommendations so that they can also lend their voice to the Community Partnership Collaborative.
That's great. So 2 weeks ago, I was at an event at Insight Medical Center, one of the hospitals in my district, and they're now in the pediatric neurology space. So I think that's an interesting possible partner, relative to the maternal health piece.
I agree.
So I've got the name of the head person. I can't remember, but I do have it, and I'll forward it to you just for your consideration.
Sure.
Thanks.
Thank you.
Thank you for the great presentation. One of the questions I had is, what's different about the approach and work on this plan compared to the previous, just given where we are with capabilities analytics, technology, what's happened with post-COVID? Are there things that were done differently? And then the second one is just about, credibility and misinformation, disinformation, and trust in public health, and if that's embedded within the context of the plan.
I'll take a stab at this, and I'm tempted to say everything is different, because in so many ways it is, particularly having the perspective of this being my third round. I think, one, we have someone who is dedicated to leading the plan, and I really don't want to underestimate the importance of that, because Dolores has really brought both a relentless attention to detail, but also an ability to ensure that our activities are coordinated and that there are connections being made between the three pillars. As you can imagine, for some of the strategies that you heard, the impact on health outcomes aren't necessarily going to be limited to one particular area. If you're working on, blood pressure control, for example, that has implications for maternal and child health, right? And just one sort of concrete example. I think the other piece is thinking really hard about implementation and ensuring that there are clear sort of roles and responsibilities assigned, and thinking about what that implementation structure looks like. And then I think finally, thinking about resources. So I just want to acknowledge here Cook County Health leadership, Dr. Makaitis, and the Office of the President in their support for our work in all three spaces that have been highlighted as pillars here. And we are having conversations right now about the budget, and we're hoping to allocate some funding to support work in each of those three areas.
And then I just encourage what you all probably think about, just given the nature of this being an integrated system, how these three priorities not only impact the community, but can be socialized and engaged, across ACH and county care, CERMAC.
Yeah, completely agree. I mean, we engaged with colleagues throughout, and I'd highlight that as a difference as well, Director Bott. I mean, we engaged with colleagues across Cook County Health early and often, including folks from service lines, from, the expertise that county care brings is invaluable. And then, of course, we've got a chief strategy officer that is also incredibly helpful.
Thank you.
So just a quick question about this new plan. You even named, community building health, community health. So I'm just curious what you will be measuring in terms of actually community capacity building when you're doing, needs assessment, and how do we measure actually community capacity as improved because of what you're doing? Because, like we talk about a lot, but like, how do you actually build capacity and measure?
So with our objectives, this is really where the Community Partnership Collaborative is going to shine, because we're right now in this implementation phase of developing these types of metrics that you're referencing. So we're going to work on them internally, but also work with our partners on solidifying them. And we have process measures that we want to identify and impact objectives that we want to identify. And I can't say that we've solidified all of them right now, but that is something that is under consideration, the concerns that you're raising.
Yeah, to build off that, you mentioned a community partnership collaborative.
Mm-hmm.
You can't do a plan like this without not only assessing the community, but listening to the community and their needs and what they perceive. There might be a disconnect between what the health conditions are and what they think their immediate needs are.
Mm-hmm.
And so could you talk about that process in terms of the level of engagement you have with the community? Because I know you did it, but it didn't come out in the presentation.
Yeah. And I want to make sure that my numbers are correct. That's why I'm flipping here, because Mr. Harrington, to your point, we definitely engaged the community. 46 focus groups were conducted, approximately 10 participants per group in multiple districts. We also had community surveys that were released as well. Anything else on this, Dolores?
No, I will just say with the community surveys, excuse me, we were more intentional about where those surveys, where we were targeting, making sure that we were hearing from populations that we typically don't hear from, populations that are most impacted by health disparities. So we were very intentional about hearing from them. And all of that, all of the 3 assessments that were conducted were analyzed to really look at what the issues were, what the themes were, and what people wanted to see as, in terms of improvements for their community. And so what we came up with, it wasn't what we came up with, it truly was what the community came up with. And we engaged the steering committee. I don't think I mentioned that from the beginning. So we had the larger body convening in July, and then they met through September, creating these goals, strategies, and objectives. But leading up to that, from the very beginning, we had a steering committee that was comprised of several community partner organizations across all of suburban Cook County that informed this plan.
And I also just wanted to put a plug for our executive summary. Is if you look on page 4 and 5, it goes through the community input, the surveys that were used, focus groups, all of that too.
Great. Thanks for the presentation. It's great to see the work actualized. I think that it's important to understand this is an unfunded mandate that has value beyond just the certification and accreditation. Could you speak to the resources, because you started to go there, but resources that are really required to make this successful? So not just the implementation of the strategies, but also the level of coordination that is required?
Yeah. So we have a chronic disease prevention and control unit that is led by Amy O'Rourke. All of them are working in some way on these strategies with their partners, current partners that they have, trying to forge future partnerships. To your point, this is an unfunded mandate. So that staff in kind work is very, very critical. When it comes to mental health and substance use, we have a unit dedicated to behavioral health led by Hannah Kite. And all of those staff are working in some form or fashion to those strategies. When it comes to maternal child health, led by Dr. Michelle Spikes-Kane, and also Diamond Ross in this initiative, we are working with nursing unit, and they are the ones that are working on maternal child health. It's a lot of in-kind resources and a lot of in-kind efforts along with these existing partnerships that we're using. To your point, since it is unfunded, that is why the Community Partnership Collaborative is so important, because their priorities around this are going to help us make sure that all of our efforts are coordinated. We're not overlapping since there is a limit in resources. Dr. Joshi, were you going to say something? Oh.
No, I think you covered it. I did want to go back to Director Bott's question earlier regarding partnerships. And as I was looking over, I realized I forgot to acknowledge the Cook County Health Office of Behavioral Health, and led by Dr. Tom Nutter, my colleague, who have been invaluable partners in this space.
So I guess as a board, I hope that we can be mindful of maintaining the infrastructure, to CCBPH. It's really important because really building out the community conditions that support the health and well-being of our residents and patients of CCH is really invaluable. And I also think there's opportunities to explore ways to align and partner with philanthropy. So happy to talk through that. Absolutely. Thank you.
I wanted to just highlight one thing, Mr. Harrington. A lot of the research and the data for our community needs assessment that informed our community health improvement plan would not have been done without our epidemiology unit led by Dr. Beth Holloway, and also Christopher Smith. He goes by Scott. So I just wanted to highlight them as well.
Yeah, 2 additional things. One, and you get to it, I think it would be helpful for some of the commissioners to see some of the data reports, because that drills down and it shows specific problems, specific areas. You talk about and you provided an overview, but we have Cook County commissioners that have jurisdiction over some of those areas. It would be helpful for them to know and be aware of what some of the unique problems are and the specific geographic location that's there. The other thing that would be helpful is the reports from which this comes. This is just a summary. And if people are really, which I am, interested in the minutia and the data, it would be helpful to share the information electronically with the data so people can actually look at the numbers and see what's happening in suburban Cook County. One of the things that in some respects is a misnomer, this term suburbs versus urban areas, because a lot of people have moved out to the suburbs now. And there's not as much of a difference as historically there's been between the suburbs and the city, because you have small cities within the suburbs, and some of the problems that used to be only unique to the city are now you're seeing in the suburbs. So I think a more complete picture would be helpful, at least as a reference for some of the other directors.
You're correct, Director. This is a summary, an executive summary that we wanted to provide because it's simply more easily digestible than the full report, which I believe is over 100 pages and includes drill downs on each of the assessments and all the data. You should have that in your inboxes, and we shall be making it available on our website as well.
And we're talking about a population of about 2 million people.
2.4 million people.
Just want to add to what Dr. Harrington said, because I'm just curious. You distributed 7,000 naloxone, and we do know that reduced overdose deaths. But when you actually say, like 80, doses were used to actually prevent deaths, it's 1%. So do we know, like, where we distributed naloxone may be, like, adjusted to target certain locations or something? So, like, the data, I'm hoping that your evaluation could show some, like, adjustment improvement.
Yes. The simple answer to your question is yes. I would say here, sometimes qualitative data can be helpful and more real-time than quantitative data, for which there's a lag. And so we're always in communication with our partners in the field who have deep relationships and expertise and knowledge of the suburban Cook County space, and sort of help us think through, like, where there may be emerging clusters and where there may be opportunities to distribute naloxone.
We have a question. So how much of what is going to happen in the next 7 months with Medicaid reductions and other things that we know are going to be happening have been taken into consideration in developing this? Because I know there's a baseline of work that's been going on, but I'm thinking about how this interfaces or reconciles with what we know is going to happen. I know a lot of these things would still be a focus, even if that wasn't happening, but we're talking about 400,000 more people. What's the impact going to be to what the county is trying to achieve within this plan? Just curious about how you've taken that information and built it into this.
Yeah. Thanks for that question. I mean, I would say it's definitely a significant consideration in the background when it comes to our planning efforts. That said, I firmly believe it's very much in the foreground in terms of the impact it's going to have on the health of the public in suburban Cook County, and of course, nationally, I view it as a major threat. And one of the areas that we're exploring is how we can get to the answer to your question, like, what do we think the impacts are going to be in suburban Cook County? Can we, at a minimum, try to document those so that information can then be used for advocacy to support, shall we say, more equitable policy making in the future?
I mean, do you have a sense of what, who the people are that would be impacted by those reductions through the lens of Cook County, whether it's public health, whether it's county care, whether it's the hospital systems?
Yeah. I mean, unfortunately, I think the impacts are going to be incredibly widespread, both to the healthcare sector and the ripple effects to many others.
That's a general answer.
It is.
I mean, we know the number, we know the universe, we believe what the state says. It's going to change, actually. So generally around 400,000 people. I think we have a sense of who those county residents are and then how they interface with the county health system. So I think there's an opportunity to zero in on that.
Yep.
So if you agree, that's good, but I think that's a question for you to, let's start zeroing in on who we think those people are so that we can target the efforts towards those people in those communities are going to be left out some way.
Thanks, Director. Sorry, I think I understand your question now. As you know, there's a lot of work that's been happening on the part of colleagues, Kathy Chan, Director of Policy at CCH, to convene folks from across Cook County to address just this issue. And my colleagues on the CCH communications team have developed, I think, really useful tools that we will certainly be out there sharing and leveraging our relationships with partners to share. You know, I would want you to know that we're lockstep with my colleagues in Cook County Health on this because of the widespread public health impacts.
Okay, thank you. Any other questions, comments? Okay, thank you. Great presentation.
Thank you.
Appreciate it. Thank you. So I do think there is some business here that we have to include with this presentation. I will ask under item 5B, the approval of the Cook County Department of Public Health Building Healthy Communities 2030 plan, which has just been presented by Dr. Joshi and his colleagues. I'm looking for a motion to approve item 4B, the Cook County Department of Public Health's Building Healthy Communities 2030 plan. Can I have a motion, please? So moved. Thank you, Vice Chair. Second. Is there any further discussion or comments? Hearing none, all those in favor say aye, please.
Aye.
Aye. All those opposed? Hearing none, that motion is approved. Thank you.
Mr. Chairman?
Yes, sir.
Real quick, this is partially my OCD and partially moving the ball forward.
Sure.
Since we just talked about public health, couple comments on the speaker that we had earlier, just that
yes.
We definitely need to engage on the policy questions around that. We should clarify that we're not the Board of Health. I believe that's a creature of the county board. We are part of the governing structure of the Board of Health, but technically they're the Board of Health and we're the Cook County Health System. But that being said, that we should definitely engage around making, around these issues that have arisen from the federal government and do our part to help vulnerable communities here within our purview.
Yep. So two things. First, I appreciate the clarification so that not just the speaker knows the difference, but everyone does. And number two, I'm sure Andrea took notes, and we'll address that with Dr. Makaitis, and we'll have a response to the speaker that's appropriate.
I could chime in now.
Sure.
Here.
Yeah.
So in consultation with Dr. Nutter and Dr. Joshi, I checked to see, it's not an organization that we're funding through ARPA. Like, I think how we're interpreting his comments was there was a cut from the city ARPA fund, and it wasn't necessarily us. I mean, we're certainly very committed to, the various groups that he mentioned. Certainly, you think of the Core Center and a lot of the work there, and we're trying to continue to get grants, apply for funding that we can distribute to community groups, and which they would be welcome to apply, but they're not a current vendor.
Yeah, and I think there was a piece on that in terms of I don't know that they were saying that the speaker was suggesting that we cut their funding, just that ARPA funding was cut, but that we.
Yeah, maybe I
was
like ARPA, that's not.
And we have a grant process that obviously that they would have to follow. I do think that there was a bigger policy question about groups in general pursuant to the state's statute that I'm not specifically familiar with, but just that, we should probably take a look at as an ongoing policy concern that I know we've discussed at the Finance Committee and discussed more broadly about our role along with the state and the city to make sure that communities that are, on the edge of Donald Trump's acts, and I'm speaking of that not in a political pejorative way, but in a literal governing way, through his execution of policy, through legislation and things like that. The executive branch, that we're there to protect these communities as best that we are able to.
Yeah, I think I interpreted the way you did, Andrea, that there wasn't a specific complaint or criticism about the county. It's just they've lost some money in another area, and they want us to consider, like a lot of groups do, that come before this board to consider a request. And as I stated, I know that Andrea and Dr. Makaitis will evaluate that as they evaluate all requests that maintain the same type of position in their communities. And so
I think I assume we're going to learn more about all that in the next 3 days as the state passes the budget. So,
see what's left, right? I don't have any report this morning, but I will have some comments in closed session for the board. And so at this point, we will move to item 7 to complete the CEO report. And I do want to recognize that Dr. Eric Makaitis is participating remotely, so just be aware of that. And we will ask Andrea to continue with completing the CEO report. She'll start with an update on the strategic plan and the ARPA obligation.
Thank you. So first up, an update on the strategic initiatives. I'll highlight a few of these things on here under each pillar, but some of the accomplishments under the quality, safety, and experience pillar include Provident having a successful Mammography Quality Standards Act survey that was conducted by the Illinois Emergency Management Agency. We're also expanding the Patient Safety Coach program across the system. We are in the process of moving the sleep lab from Stroger to Provident to utilize the 6th floor at Provident. And CCDPH's Healthy Beginnings program, which we heard referenced this morning, is really gaining traction across multiple media outlets with a lot of views and information getting out to people. Under workforce, we're pleased to share that we had 50 graduates from the 18-month Frontline Leadership Program. We've also continued to see reduction in our vacancy rate. For NNOC, it improved down to 22% from 28% earlier this year. And overall, we've actually gone below 20% as of the last couple of weeks. HR and budget are working on some process improvements to have salary approvals earlier in the recruitment process to improve hiring efficiency. Under transformation and growth, you'll hear more about this later, but the Total Health Talks campaign is really a popular podcast. I encourage you to follow that wherever you get your podcasts. Also, CCDPH Emergency Preparedness Unit conducted a tabletop exercise to focus on administrative preparedness, so to ensure rapid procurement, hiring, finance, and management in the case of an emergency. Supply chain is undergoing a comprehensive enterprise-wide assessment of operations to improve expenses and operational challenges. Under fiscal resilience, we have, I think you're familiar with the Get Medicaid Facts website and toolkit. Alex will talk more about that later, but that's been getting a lot of play in the media. We also we're pleased to lend our support to a bill, to legislation that passed to protect uninsured patients with a standardized application for financial assistance and to require it to stay in effect for a year approval timeframe. Our APPs, our advanced practice providers, have had a utilization task force, and through that process, they identified ways to increase their schedules and the number of people that they could see and serve, and we expect that to generate annually additional $3 million in revenue. And finally, some of the things coming soon on this, County Care has been implementing a significant number of initiatives to achieve cost savings of $50 million, and we're working on a revenue cycle dashboard for our clinical departments and providers. So with that, we'll go to ARPA. So the last time I was before you, we had $50 million left. Now we're at 43.8. So that's some good progress. If you recall, just the majority of our spending will take place by the end of September, but we have kind of a run-out period to pay final bills through the end of the year. So we'll continue to report progress as on a monthly basis through the end of the year. So if there are any questions, I'd be happy to take them.
Any questions for Andrea, please? Okay, this is not an item we vote on. It's informational. So now we will go to the divisional report, marketing and communications, presented by our Chief Marketing and Communications Officer, Alex Normington.
Hi, good morning, directors. Thanks for being here today. I'm Alex Normington, Chief Communications and Marketing Officer. I'm here with a couple of my colleagues, and we're thrilled to provide you with an update on our communications and marketing activities. We're in a really competitive healthcare environment. So through our work, we strive to position the health system as a provider of choice, to encourage people to engage in with the health system for care, both current patients and prospective patients, to burnish our reputation, help the public see the value in our county health system, and also support recruitment and retention efforts. A significant portion of our work is also focused on public education about pressing health issues and wellness, and we feel like that we have the privilege of that obligation as a public entity. And so Kate and Luis will talk a little bit about that because it's a critical part of how we serve our communities with the goals of achieving equity and engagement driving our strategies. I'll note that this update is really focused on CCH as a provider of care and how we talk about the health system. There's regular updates on county care marketing efforts, Cook County Department of Public Health campaigns. So we wanted to focus on clinical services for you today. And I'd also like to thank my colleagues and on the executive team and Dr. Makaitis for their support of our work. Marketing and communications efforts really could not be successful without our work being embraced as an organizational priority. So thank you all for everything that you do to support us and make our work possible. And of course, Kate and Luis are here, two of the outstanding directors on our team are going to talk about their areas of work, but it's really a testament to the entire team. We have Marta Guzman-Mariano, Cheryl Booth Davis, Amani Harris, who also support the health system, and they'll be talking about the work we do together collaboratively. So without further ado, I'll turn it over to Kate.
Good morning. I'm excited to be here today to update you on our earned media and social media teams are doing to elevate the reputation of our health system. We, as Alex mentioned, operate in one of the most fiercely competitive healthcare and media markets in the country. So we aren't just competing with other hospitals for patients, we're competing with them for limited news cycles and finite consumer attention. To win in this environment, our team categorizes our media strategy into three distinct strategic buckets. First is our responsive media. This is our baseline. When reporters need an immediate, trusted expert on seasonal flu, extreme weather, or public health updates, they call us. This fulfills our mission as public health educators, but it also builds institutional trust. Second is trend-driven placement. This is where our team, including Imani Harris, Tracy Litwin, and Marissa Guzman-Laureano, who help support our Spanish outreach, actively insert our physicians and our health system into breaking national and local health conversations. Third is feature storytelling. This is our proactive pipeline. We partner with our teams across the organization to showcase powerful patient triumphs and program highlights like our Get Medicaid Facts platform and our Food is Medicine initiative. This is what humanizes our brand and showcases our clinical excellence. This aggressive strategy is paying off. We're seeing growth in overall media coverage coming off a strong 2025, as you can see in our year-over-year metrics, and we continue to see increases in our Spanish language media, which is vital to the communities we serve. Overall, our total estimated reach, which is the potential size of the audience that sees each media piece we've placed, totals more than 4 billion people this year. I'd also like to point out a few other media metrics. When you look at our media value on the screen, think of it as our earned media ROI. If we had to buy traditional advertising to match the footprint that our team earned through organic news coverage, it would have cost the system $39 million. This is massive brand equity built with incredible fiscal efficiency. And I want to point out how competitive our presence is in the media market by highlighting the media benchmarking. Looking at top local print and digital pieces, we represent more than a quarter of the stories in comparison to 5 of our competitors. We are ensuring that CCH is well represented in all forms of media and is able to tell the stories that showcase our institution's excellence. Next slide. Moving to our digital footprint. Social media is our direct, unfiltered channel to our patients.
Oh, yeah.
Yeah, I'm trying to understand this $39 million in terms of earned media. That's media that we got, we didn't pay for. Right?
Correct.
I want to make sure that's specific. Okay. And the other thing is, we don't do any paid media, so all of this is earned.
I'm speaking just on earned. Luis is going to talk about paid media.
Okay.
There's a few outlets that we will occasionally place a paid opinion piece or informative piece, and it is generally based on need, where we see that outlet would reach an audience that's really critical to us or might be underreached. So, but what Kate is speaking to is truly just our earned media with news outlets, mostly in the metro area.
Thanks, Alex and team, for all your work in this area. One of the things I see is just an impact on jobs in media and just the landscape. So has that impacted our relationships and where we have pathways to drive earned media? And what do we do about that?
Yeah, we've seen a significant decline, one, in the number of journalists in the market overall, and especially the number of healthcare journalists. I think there's only a handful of outlets that actually have individuals who are dedicated to health. Otherwise, we're working with traditional reporters who are covering different topics day to day. So that makes it puts more of the onus on us to create stories and pitch them out that are fully baked, that the reporters have to do kind of less legwork about, or maybe they're not as informed about a health policy topic, about a health condition, and we have to provide that education. So we try to keep our relationships with reporters really strong, regardless if they cover health or other topics, because we work with them regardless of their beat, because you never know what someone's going to be assigned to. But it's been a really challenging few years in particular for the media market in Chicago and nationally.
And then I think the other thing that just would be interesting to know is search is evolving to generative AI. And so where we show up on the generative AI searches as opposed to regular traditional search will be interesting in terms of, are these key campaigns and issues showing up there as well?
Yeah, I think that's a great point. Digital marketing, which Luis will talk a little bit about, is one of the most cost-effective ways to reach people from a paid perspective. I'm really thrilled that our department has continued to build in our sophistication and our tech capabilities, and that's thanks to our agency partner who's helped us and kept us really on the cutting edge. And I think AI is that next frontier. It's not just Google searches as if someone's looking to ChatGPT and other platforms for medical support. How can we make sure that we're there for them too?
Yeah, because Copilot Health, Anthropic, and OpenAI all have platforms where folks are engaging around health questions.
Absolutely. Okay.
Thank you.
Thank you.
So moving to our digital footprint, social media, like I said, is our direct, unfiltered channel to our patients. In the first few months of this year alone, we've published more than 900 pieces of targeted content across Facebook, Instagram, X, LinkedIn, and are growing our TikTok presence as well. But volume isn't the goal, engagement is. Our followers and interactions are up, which is a testament to the quality of content that we are putting out there. Next slide.
Need a board member on TikTok.
As you can see from our Facebook benchmarking metrics, our content has high engagement and has led to an increase in followers over the last few months. We use traditional and social media to highlight the human side of medicine, and while not every patient story fits into a 2-minute evening news broadcast, every story has power. On social media, we can highlight the incredible dedication of our frontline staff and show patients they aren't alone in their healthcare journeys. Unfortunately, we're not able to show this video, but I encourage you to visit our social media pages to hear the story about John. John was experienced a stroke several years ago and has been working with our speech therapist to regain his ability to speak. And his story is not unique. There are people who suffer strokes, and but I think his story is powerful in the impact that CCH has had on his life.
We'll send that link around with board material.
Our earned media and organic social strategies ensure the market knows who we are and trusts what we do. To talk about how we amplify that message, I'm going to turn it over to Louise.
Thank you very much, Kate, and thank you, Alex, and good morning, everyone. And thank you very much for the opportunity for us to share some of our marketing initiatives. And today we would like to talk about the HIV Integrated Services campaign, also talk about the Provident campaign, our podcast, Rural Health Talks, and conclude with a group of campaigns that are supporting public education. So let's talk about the HIV Integrated Services campaign. I enjoy very much working in this campaign and actually highlighting the great job that the core team is doing. And to provide a little bit of background, the core team won a grant from CDPH last year to promote their HIV services. And we did so targeting the LGBTQI community with the creative that you see on screen, Getting Some. And that was done over the summer months. This campaign was very successful, so much that the CDPH team provided an additional grant to the core team to continue this campaign. Now, this time around, we face a different reality, and this is something interesting that actually Mr. Calderon that presented here earlier actually mentioned. There is Black and Latino communities continue to face a higher HIV infection rate. There is a stigma around getting help or treatment or prevention, and of course, they're not going to reach for care. Some of the stats that you can see here under the women's side, Black women actually represent 50% of the new cases of HIV infection, while Latino represents are 3 times more likely than their white counterparts to get infected. Around men, Black men are 8 times, and Latino men are 5 times more likely to get infected than white males. So with this information and this insight, actually we crafted our goal. And our goal was to drive awareness, trust, and engagement across these priority communities. Why? Because actually CORE has been in the community for a very long time. They have credibility, they have the knowledge, and they have the expertise to provide this service. Our approach was to meet people where they were, and we did a culturally relevant and bilingual campaign. And the media mix was composed by digital with social media, search, audio, dating apps. Dating apps was a big tactic for us. We did out of home with the bus shelters, billboards and posters. We did some like hyper local posters, the posters that were placed in locations where these communities will visit. And one additional layer that we did this time around was community engagement. So the core team actually helped activate, under the guidance of Marcelino Garcia's team, this community engagement piece. So the LGBTQI campaign Getting Some ran between January and March this year. The women campaign, Love Yourself Loudly, started in April and is going to end this weekend. And between those two campaigns, we have reached over 18 million impressions, over 150,000 clicks, and over 2,000 calls. One of the coolest things that we've seen here is that we have been directing people to the website, and people have been spending over 5 minutes in the website looking for information, and that is double the industry benchmark. As I mentioned, the women campaign is going to end this weekend, and then the men campaign will start in July and will end in August. Any questions before I move forward?
Were you also trying to drive them to core?
It is the core website, yeah.
Oh,
It is.
okay. So are you looking at like both, getting services or reaching out? Like
Correct.
Okay.
Both. We were looking for them to get information about the services that core offer, and also to have them call if that is the one thing that they wanted to do. So.
Yeah, and I'm also curious if there's opportunities to partner with CCDPH and CDPH, because they also.
Yes, they did. We did. We have actually the same campaign assets were promoted via the CCDPH social media channels with minimal pay social media. Yeah.
Great. Thank you.
I will ask the basic question here. Whenever I hear statistics about Black and Latino, or 10 times, 30 times, whatever, of the white population, I always ask the question, why? So here, when we're looking at HIV, which is, again, this is nothing new. This has been around, at least knowledgeable since 1984. Why are we still seeing that? What is the issue that those communities are seeing versus majority community?
Yeah,
That's my question.
That's a really good question. I think that the answer is going to be really complex and related to current and historic barriers to care, stigma, and other factors. And I think probably the clinical team would be best positioned to answer that specifically. Sure. But you're absolutely right. It's something we always try to keep a mind on of, when we're trying to get a key message out there, who needs to hear it the most and why.
So that's the objective of your campaign, is to try to get the information about what you should do to protect yourself?
To let them know that we have the services to protect them and to encourage them to actually get preventive care. Yeah. Or care if they need, if they are already infected.
Okay.
Mm-hmm.
Yeah, as I listen to the question, then the percentage relative to the population, and Blacks and Latinos still minority population. So their population is less than the majority population, but the rate is higher. So that says something more about what's going on at a community level than it does about race, or at least the group level.
Yeah, I agree.
Just quickly, I'm blessed to have a queer son, and he takes PrEP. And I've also had friends in the white community who are queer, and they take PrEP. Is that something that we're talking to our individuals about throughout Cook County and our community?
Yes. Part of the campaign, actually, a group of the creative assets of the campaign, they talk about PrEP and other type of medicine, I'm going to say, that actually you can take post action, I guess, so to prevent getting infected. Yeah. Thank you.
Next slide, please.
Thank you. And so next, let's talk about the Providence Hospital campaign. And I want to thank Dr. Turner and his team for the support here, and also Nancy Manny-Harris and Marisa Guzman-Laureano for their support in activating this campaign. Last year, in the summer months, we were hearing that people within the Providence catchment area were not going to Providence. So we wanted to understand what was going on, and we did a research to understand what was going on. And the research actually told us that there is an opportunity to increase awareness and of the Providence Hospital in the catchment area, actually utilizing and leveraging the legacy, the expert care, the convenience and their availability. So we, with that information in mind, we drafted our objective to, drive awareness, trust, and patient consideration by reconnecting the South Side to Providence. So our approach here was also a hyperlocal campaign that was bilingual and culturally relevant. And our media plan included digital with, again, social media, search, audio, out of home with both bus shelters, billboards, and posters. And we did something really cool that I like, but there was a green line takeover on 51st Street. We did it to target the elderly population, direct mail, and we also developed some community engagement material. This campaign was divided in 2 phases. Phase 1 was digital only. The reason we did a digital only phase was because we were reacting to what we heard on the research. And this digital only phase actually ran from October to December. Some of the great results that we saw here in terms of creative was that the carousel that actually displayed the legacy of the hospital was really well received. And also we did a set of digital assets that talk about or had some testimonials. And there is one portrayed here in the slide that I'm sure you cannot see, that starts saying a world-class experience at Providence, and then goes on about talking about great about the hospital. We dropped the mailer in January, mid-January, and to around 130,000 households. And phase 2 was the phase that actually contained all this media that I talked about, and you can see on the right some of the creative that we did, the billboard, the 51st takeover, and some of the out of home. Other media that actually was well received were they provided LED video, and the community here paid attention. We had like over 45 million impressions, over 90,000 clicks, over 3,000 calls, and the website traffic increased 5-fold. Any questions here?
So you're able to track whether it in fact led to more people using the hospital?
So a few points on that. The goal of the campaign was to drive awareness, to make sure that more people knew that Provident was there and able to care for them. We're able to track the engagement that we receive through our ads. One of the opportunities we have as we get more sophisticated with our technology internally is to identify when someone's calling the call center to make an appointment, what's happening with that person. Are they making an appointment? Are they getting requested for a referral? Or what is their journey through the process? Because right now we're telephone-based. If we were digital-based, we could track more directly. Someone clicked and made an appointment successfully. And so that's a piece that we're still hoping to build out as we transition to online appointment making, and that'll give us more visibility. Unfortunately, as I think Andrea can speak to, we have not seen increased volumes at Providence. We saw great awareness and engagement in our work, but the census has remained relatively low.
But a different question, which is still similar to the question that was asked, is can we say, well, first of all, did we see the population or the census going down? And then did we see it become flat? If it become flat, and then we can try to see link up, did your campaign actually help to stop that? And that can be answered by when they call in for a question or for an appointment, how did you hear about it? What prompted you to do it? So that's the question I'm asking. Are you doing those type of things?
We are working with the call center so that they do know when we're in market. And so we try to gauge, at least anecdotally, how people are coming to us. And because the campaign just wrapped up this spring, we're waiting to collect more information about, in the coming months, will we see more of a stabilization in those volumes? And Andrea, I don't know if you've got anything you'd like to add about, the daily census.
Yeah, I think it's probably more likely that you'd see an impact on outpatient services rather than, you don't make an appointment for an inpatient stay typically. So I think that's where we need to look. And generally, we have seen a higher demand for the outpatient services at Provident, the emergency room, a lot of our primary care and specialty care there. So I think that's what we need to look at in terms of the impact of the numbers.
And last year, we did do a micro campaign for specialty services at Provident. And I don't have that data in front of me, but working with the department to analyze year-over-year volume, we did see an uptick as after that campaign ran. And so we'll be able to do a similar analysis in the coming months once we get a full picture of the schedule.
And I think you said this, but I encourage you to definitely go back in time because we want to see the difference on what was happening to be able to understand the impact. Because if you're getting this type of engagement, that's absolutely fantastic. But when it's all said and done, are we getting more people inside the hospital? Which I love the work. So please don't take anything that I'm saying as a criticism. I'm simply trying to say, let's see if we can find a way to track it and be able to prove the point that you are doing great work, which I think you are.
Any other questions? Next slide, please. And let's talk about the podcast now. And I want to say that a key part of the success of the podcast is my partner in crime, Marisa Malariano, that she was here. And she has helped actually grow this podcast a lot. We came across this insight a couple of years ago that 192 million Americans were listening to podcasts, and actually we wanted to jump into this opportunity. And in April 2024, we launched Total Health Talks with 4 distinct episodes, one about the diet and nutrition, one about cardiology, one about oncology, and one about men's health. And our approach for this podcast is to create content that is very digestible for our communities. One of the things that we identified from the beginning is not only to do it audio, yes, we do it in audio and distribute it via the audio channel, but also do it in video. There is a trend actually that is stronger, the podcasts are being distributed in video, and it's a strong distribution channel for us and for everybody else. We have a content cadence of about 1 episode a month. It's a little more sometimes. We have 14 episodes a year. And we have covered a wide variety of themes that I cannot read from here. We take each one of these episodes and actually we promote it in social media with a very, very minimal budget. And that actually has led us to double our awareness from 2024 to 2025. And 2026 is actually pacing to be a really good year for us also in this respect. The podcast has won a couple of awards. This year has won a Health Ad Award, a silver winner. And last year we got a Pinnacle Award, the best in class, and you can see Marisa there receiving the prize. About the episodes, I believe all the episodes are very interesting. The ones that are a little bit more engaging, they talk about prevention, preventive care, and emotional wellness. And I think there's a thread among all these episodes that they have simple and relatable information that is appealing to the community. We have done a total of 32 episodes, and if you have not had a chance to listen to the podcast, as Sandra said, please do so. The link is in the bottom right of the slide. Question?
Yes. On the podcast, here's a question. Are you linking that to any particular department within, whether it be Stroger or Providence? Hence, because if you're having that type of an impact in that audience, the question becomes, can I now use that as a way to pull them into the location? Especially if you have the experts from those locations putting forth where the organization has a spike so that everyone says, forget about this is called Stroger, forget about this is Provident. I'm coming to see Dr. Such and Such. Because now it's just like when you're applying to graduate school. In graduate school, you don't really care if the university is great or not. You care what that PI is. Does that PI have the right research that's going to allow me to be able to advance? So then if that becomes the strategy that we use here, then I don't really care about what I've heard about them. I care about that particular person. She is going to get me well. She's going to help me. If we can use that type of strategy, that may change the game because you have the way to reach the audience. Now the question was, can you pull them in?
And absolutely, the goal of the podcast is to highlight specific providers to gain interest from folks who might not already be engaged in our system for care. And that's been one of the main focal points, is to create kind of general, very interesting subject matters, and then weave in the CCH component to hopefully drive that interest.
But my question is, in that weaving, are you putting in there that we are leaving a certain portion of our scheduling open for some of our podcast listeners, so that now people feel incentivized to come in and actually try to do it? Because once you've engaged that person, you have them. The question is, can you get them to walk through the door? And if you make the opportunity to remove those barriers, it'll happen.
Yeah, we're not able to save schedules, unfortunately, but we are able to direct on how you can make an appointment for more information.
That's
I
right.
don't think it'd be realistic. I don't think it would be realistic to keep a schedule open, because then you have unused capacity because you're waiting for people to come in. I mean, if they're engaged to come in, then they're going to make the connection and you'll get them in.
Well, here's the question I would ask, Chair. Is there a ramp up period? Because whenever I understand exactly what you're saying,
Right.
but if that cost of allowing them to fill the pipe up, then once it gets filled, now have you actually
I
created?
think the question is, have they anticipated a projected uptick in activity coming in? And
Fair
if
enough.
they have,
Okay.
it's built in to that schedule, I would assume.
Yes,
Yes,
by
Director.
my count, there are about 7 hospitals on the south side of Chicago. Providence is one of those hospitals. The question is, where are we? Are we number 1 in terms of utilization, number 2, number 3? There may be a way to look at it in terms and see who's on the south side of Chicago and what their volumes are and where we fall in terms of that. Because people have options.
And that's what came out loud and clear in some of our research, is that a lot of the folks that, I was going back to the Provident campaign, who are in that Provident catchment area, the vast majority go to USC.
So I've done a number of podcasts talking about my prostate cancer journey and renal cancer journey. And of course, that's what led to the birthday health screening program. If there's any interest, I'm happy to sit down and do a podcast with you.
And the other thing I think about podcasts is consumers and those stories from patients about how they think about some of these issues might be also a good way to connect with others.
Yeah, that's a great point as we look for our evolution.
There isn't any other question. Next slide, please. And to conclude here, we're going to talk about a public education campaign. So a major part of our work goes beyond actually promoting healthcare services. We help communities better understand, how to access services, why early care matters, what preventive resources are available. And at the center of all this campaign, for us, there is a simple conviction that is that the healthcare information should be clear, accessible, and actually welcoming. So here we are showing some of the campaigns we have supported, like the birthday screening program that provides free annual check-in for underinsured individuals. We have the Medicaid Get the Facts campaign that Dr. Joshi mentioned, and it's very relevant, responding actually to the HR 1 bill that the government passed, and it's in market right now, and it has had a really good result. We are all welcome here, that is reinforcing County Care's commitment to the community and its diversity. And we have the Food as Medicine campaign that is, about nutrition, education, and health food access. We have also done some other campaigns around promoting, for example, Robbins Health Center, and we're planning a campaign to promote prenatal birthing and pediatrics. And here, whether the goal is awareness, prevention, or building trust, each campaign is designed to make healthcare approachable and understandable, and actually for us to connect with the communities we serve. Any questions?
I'm just curious, because and maybe because I'm biased, because I'm on the board and I see a lot of the campaigning when I'm not in the building, just in my day-to-day life, but I don't really see any other health systems put as much effort or information out there like we do. Is that a reality? Is that Is that generally what your comparative analysis would show?
Yeah, I would tend to agree, and I
Yeah.
feel like as a public health system, we have the, privilege of being a source of truth and information, and it's not necessarily only promoting our services and our provision of care, but it's letting people know what they can do to stay healthy, letting
Yeah.
people know what services are available, and then also what's changing or what do they need to know. And that's, I think that's a huge component of increasing our visibility and reputation, and also helping not just our patients, but the public at large understand the value of a public health system.
I think it's authentic and it doesn't feel self-serving because it is an educational awareness campaign as well, to your point about how we can all live healthier. And I think that's what makes it authentic. And unlike some of the other slick stuff that I see out there, other health systems, but yeah, it's done well. Not only is it done, but it's done well. So appreciate the presentation. Any other questions or comments for the panel, I would say?
Great work.
Thank you.
Yeah, thank you. Thank you. Appreciate it. Okay, well, that concludes the business portion and presentation of the board meeting for today. The board will now be going into a closed session, and action is expected to be taken when the board returns to the open meeting. So at this point, I'd like to ask for a motion to go into a closed meeting pursuant to the following expectations to the Open Meetings Act 5 ILCS 120 /2 C 1, 2, 11, 12, and 17, and we will need a roll call vote, Madam Secretary. Yeah, I'm sorry. Thank you, Vice Chair. I do need a motion. You're right. I think I heard a first and a second. Okay, Madam Chair, please.
Roll call vote on the motion to go into closed session. Aye or nay? Director Bott?
Aye.
Director Harrington?
Aye.
Director Kim?
Aye.
Vice Chair Lowry?
Aye.
Director Masuda Barnett?
Aye.
Director Ryder?
Aye.
Director Robinson?
Aye.
Director Sorrell? Absent. Director Staines?
Aye.
And Chair Garza.
Aye.
You have 9 yeas and 1 absent.
Thank you, Madam Secretary. So we will need a few, the motion carries. And we will need a few minutes to clear the room. And only counsel and Dr. Makaitis, who is participating virtually, and the secretary should remain in the room besides the board members. Thank you.